So as you can tell, I may live in New Zealand, but I'm certainly not from New Zealand originally. But I have lived there for longer, about 27 years actually I've been there. We look at things slightly differently from the rest of the world. And so we may have some slightly different takes when it comes to managing different sorts of disorders. But today what I want to do is just to give you a sort of snapshot of how in my clinical practice, how we might manage VTE in pregnancy. Is one thing that we are very well known from, and I'm not talking about hobbits. We have a fabulous, the world's best rugby team, I have to say. I'm a strong supporter of the All Blacks. So we've talked a little bit this morning already about which controversies we have in thromboprophylaxis, and the big question really is, which women need thromboprophylaxis? I mean, as you heard this morning, in the UK, it's recommended that 1 in 3 pregnant women get thromboprophylaxis for a disorder that occurs in about 1 in 1,000 women, which seems to be a little bit of overkill. So I want to talk about that a little bit. I also want to just talk a little bit about the doses of thromboprophylaxis as well. I can't possibly cover everything in the small time I've got. So you've already heard about Virchow. His birthday would have been tomorrow. He would have been an awfully old man by now. But it's on his birthday that we celebrate World Thrombosis Day, a day when we're trying to highlight the issue of thrombosis on a global setting. And the 3 things that he discussed that would contribute to thrombosis are hypercoagulability, stasis, and vessel damage. And in pregnancy, all 3 aspects of Virchow's triad are affected. Women are hypercoagulable, they've got an increase in the procoagulant fractions, a reduction in the natural anticoagulant, and an increase in things that inhibit clot breakdown or fibrinolysis. There's definitely been demonstrated that there's an increase in the diameter in the major leg veins, and this is associated with a reduction in the velocity of blood flow, which is much more marked on the left than on the right, which may be to do with the pressure of the iliac artery as well. And also when we talk about vessel damage, clearly there's a lot of vessel damage when it comes to caesarean section, but there also may be a degree of vessel damage with vaginal birth as well. And also remember, pregnancy itself is a pro-inflammatory condition, and this also to a degree will damage the vessels. So you're all aware of the maternal mortality data from Embrace and CMAC. And basically we know that pulmonary embolism is a major cause of maternal death in the UK. But it only kills about 1 in 100,000 to 2 in 100,000 women in pregnancy. So again, yes, it's important, but it is a relatively low risk. And we've heard about the rates of pregnancy-associated VTE, depends on which population you look at, but it can be anything from 1 in 450 to 1 in 1,600. We've also heard a bit about the timing of presentation, and this is a study that a review that I published 2014, that should be, and this looked at 18 different studies about when these VTE occurred, and you can see half were antenatally and half were postpartum. And while there does seem to be a preponderance of VTE in the 3rd trimester, importantly, they can occur in the 2nd and the 1st trimester too. And Ian's already showed you this slide. So why in New Zealand might I have a different a take on how we manage it? Is it because we've got a different risk population? Are we looking at different mothers? Well, just to give you an idea that we're pretty much similar to the UK, this is we also do a maternal mortality review in New Zealand where we review all maternal deaths. We've modelled it on the UK method. And we've been doing this now since 2006, and for a number of years I was chair of the New Zealand Maternal Mortality Review Committee. And venous thromboembolism is the 3rd most common cause of direct maternal death in New Zealand. Actually, totally aside, the most common cause of maternal death in New Zealand is suicide. But our maternal mortality ratio for VTE is about 1 in 100,000, and we've had only 6 deaths, but remember we're a much smaller country of 4.5 million women, 4.5 million people compared to the UK. So our figures are pretty similar. Just to give you some local data, this is a study that we've looked at. We've not published this quite yet, but we're getting to do it, where we looked at women with acute VTE in pregnancy and up to 8 weeks postpartum who we identified. And our rates of acute VTE associated with pregnancy were about 1 in 250, so very similar. And just to give you a little bit more background, just a small proportion of our women had previous VTE, about 1 in 8 women had a previous VTE. And again, our data would suggest actually that, this is a small number relatively, but a quarter of our women or so had a postpartum, and quite a lot of our women had antenatal DVT, or PE, and see there was quite a high proportion in the first trimester. So, look, we've got lots of guidelines, I think we should probably call this guidance rather than guidelines. Guidelines suggest to me that there's a lot more strong evidence to support what we are suggesting should be done. There's the chest guidelines, which are now replaced by the American Society of Hematology guidelines, and actually Ian Greer and I are on the group that are reviewing these. You've got your wonderful McLintock guidelines, which I think are really important. But one of the things about these guidelines is I've gone to many places in the world, and these are used as the Bible about thromboprophylaxis. And that's a little bit concerning for me if people take them they use them so strongly that we are driving thromboprophylaxis use globally, when perhaps we should be a little bit less. Maybe we shouldn't be giving so much thromboprophylaxis. And then a few years ago, a group of New Zealanders and Australians and I got together, and we put together our own, what we call recommendations for prevention of pregnancy VTE. Now, possibly one of the differences is certainly with the American Society of Hematology guidelines, it's a very formal, systematic review of the literature. The RCOG, you've got classification of the evidence levels, and to be honest, in pregnancy, I don't really see we can get very many recommendations above a C level. There are a couple of A's in your recommendation. One is about the use of low molecular weight heparin in pregnancy as in preference to other anticoagulants. I'm not sure even that reaches A-grade evidence. However, most of them I think are probably good practice points. Now, in Australia and New Zealand, we're a little bit more relaxed, and I think we practice what I would call GOBSAT recommendations, which stands for good old boys sat around and talked. And possibly what we get to in the end is a very similar set of recommendations. And I summarised these in the paper that I wrote, and basically, if you look at the ACCP guidelines, now the ASH guidelines, the American College of O&G, the Royal College of O&G in the UK, and our Australasian Society of Thrombosis and Hemostasis and the Obstetric Medicine Society of Australia and New Zealand, if you've a woman who's had a previous VTE, we pretty much across the board would recommend antenatal and postpartum thromboprophylaxis. One caveat I've got to say that with ours, if you've had we suggested that you would get thromboprophylaxis if you had a clot previously on the pill if there are other risk factors, and that was because one of our members didn't feel so strongly about it, so that was a grade 2 level. The other thing is here, the Royal College of O&G here would suggest that if you've had a blood clot previously with major surgery, you should have thromboprophylaxis started at 28 weeks gestation, and that differs from all of the other recommendations. So pretty unified with that. And you can see here, we've heard that's 1 in 3, and I know there's a big push now in the UK to give women with IVF thromboprophylaxis. So, I mean, most women with IVF tend to be over 35. They probably wouldn't be smokers, generally not, and they might have a multiple pregnancy, and they might have a BMI that's above 30. So, yeah, you're giving a lot of your IVF women thromboprophylaxis. And the other thing that I really don't fully understand with the McLintock guidelines is where, in the most recent iteration of the guidelines, the 28 weeks has come from. Now, I understand there is some evidence that suggests that the third trimester VTE are more common, But I know women who have died of PE in the first trimester. My message is, if you really think a woman is at risk of PE or DVT, you should start her thromboprophylaxis as early in pregnancy as possible. Because I can't predict if a woman who's got the risk factors is going to get the clot in the first trimester, the second trimester, third, or in the postpartum period. So it really does confuse me, this recommendation. And I certainly would feel very uncomfortable taking this to my practice. Another place where we don't agree very much, actually, really, is when it comes to thrombophilias. Now, outside the setting of pregnancy, in management of VTE, we don't recommend testing for thrombophilias in people who've had a DVT or a PE. There may be a potential to do it in pregnancy, because if you come from a family where people have had PEs and DVTs, then maybe if those families also have a thrombophilia, then you might be more likely to give the thromboprophylaxis to a woman who does compared to who doesn't have a thrombophilia. But really importantly, remember, only half of the patients with PE or DVT will actually have a thrombophilia. So there's another 50% without a thrombophilia who also have an increased risk of PE or DVT if they have a family history. However, just to illustrate the differences here, the RCOG, it's pretty strongly recommends that women who have a thrombophilia should get antenatal and postnatal thromboprophylaxis. And this is really different from the American guidelines here, especially from the ACCP and the new ASH guidelines. And we're all looking at the same data, and yet we come up with quite different recommendations. And this is just in women who don't have either a personal or a family history. You can see very strongly here the ACCP recommends against thromboprophylaxis, whereas on the one hand here, I would say this is the other end of the spectrum, the RCOG, and we're somewhat in the middle. Now, the one thing that really amazes me about the ACCP guidelines, this is factor V laden in the prothrombin gene mutation homozygous. Now, I don't have a problem, frankly, with the fact that if you're a pregnant woman with no personal history of VTE who's homozygous for factor V laden, studies pretty much suggest that you've got a 1 in 10 chance of having a pregnancy-associated VTE. So I'm very happy to give those women thromboprophylaxis. However, the data for the homozygous prothrombin gene mutation comes from one single case control study of women with pregnancy-associated VTE, where 2 of the women who had a pregnancy-associated VTE were homozygous for the prothrombin gene mutation. There were no women in the control group, so they estimated what the rate would be, and that gave an odds ratio of 26, with very wide confidence intervals. Look, 1.2 to 560. And on the basis of that, they recommended that women with the prothrombin gene mutation in the homozygous form or the factor V laden in the homozygous form should have thromboprophylaxis in the postpartum period. Now, I'm just very, very sceptical about using this one study with tiny numbers of women to drive such a major difference in treatment, whereas you can see this one's got very many more women, and I think we have to be very careful when we interpret such small numbers and data. So, which women need thromboprophylaxis? To be honest, we don't really know yet, and I think as Ian has said and other people have said, we need more information. I think possibly thromboprophylaxis for 1 in 3 pregnant women might be too many, but I don't know whether or not 1 in 10 or 1 in 25 or whatever it is the right number. So just a little bit now about what dose of thromboprophylaxis. Now, you might have seen downstairs that there's a study called the high-low study. And this is a low molecular weight heparin study where they're looking at 2 different doses of thromboprophylaxis. And you can see the rationale for the study is you give a fixed low dose of low molecular weight heparin or an intermediate dose, and they're following up these women for 3 months postpartum and trying to see if there's a difference in the rate of PE DVT in these women. It's actually not a single fixed dose, in fact. It's a variable dose depending on the woman's weight and depending on the low molecular weight heparin. So you can see if you're over 100 kilograms, you will not get you will get a higher dose than if you're under 100 kilograms. And the intermediate dosing as well is pretty complex, actually. You can see with all the intermediate doses, it goes up with weight. So this is not looking at two different doses. This is actually looking at quite a complex dosing regime. So unfortunately, I think this is going to make the interpretation of this study rather difficult. Now, where does the study come from? Well, it came from this study here. The rationale came from this study. This was a Dutch cohort, looked at 126 pregnancies and 91 women who were thought to have a moderate or a high risk of pregnancy-associated clot. In the high-risk group, they included women who had asymptomatic antithrombin deficiency, who were homozygous for factor V Leiden or the prothrombin gene mutation, or had combination thrombophilias. Or if you had a personal history of VTE, there was idiopathic, so no risk factors, a single VTE with a thrombophilia, or a woman with a recurrent VTE not on anticoagulation. And these women were given antenatal and postpartum nadroparin. The intermediate group, a family history of clots with no personal history with a thrombophilia, as listed here, no personal history of clot, but a family history and no thrombophilia, and a single VTE with a risk factor that included, look here, the conservative pill, the COC, the pregnancy or immobilization, and these women only received nadroparin postpartum. Now, you can see the numbers of pregnancies. There were 7 recurrent VTEs in the whole cohort. They were all in the high-risk women, okay? And look at these clots. One of them was in a woman who'd started thromboprophylaxis at 9 weeks. She's had 2 previous DVTs and she got a clot at 11 weeks. Another one was in a woman who didn't start thromboprophylaxis until 22 weeks and had a previous big pelvic DVT, and her recurrence was improbable. In the postpartum, there were 2 women who got clots while they were being thromboprophylaxed. There was one woman who just was reported, she got a thrombus related to an intravenous line. She'd had a previous idiopathic clot, so she didn't get another DVT or a PE. And these 2 women here actually got their recurrence when they'd stopped thromboprophylaxis. So to me, this is not a failure of thromboprophylaxis. This is just, perhaps not continuing the thromboprophylaxis for long enough. So when I look at these numbers, I would say that the overall rate of recurrence is about 3%, 1.6 antenatally and 1.6 postpartum, because I would not have included this antecubital fossa thrombosis, and I wouldn't have included these 2. The other thing is was that dose of nadroparin too low? Because the Dutch guidelines recommend that if you're over 70 kilograms, you should get a dose of 3,800 units of nadroparin. And 3 women in that cohort had weights of over 80 kilograms. So again, it might not have been a failure of that dose of thromboprophylaxis as a thromboprophylactic dose. It might be that was too low a dose. And also, would give you an idea of this, one of the women who was on 20 milligrams of enoxaparin, which is a bit low. So to go from there to then develop a high-low study makes me feel a bit uncomfortable. So what we've done in Auckland, and we haven't formalised all this data yet, I'm just going to give you a snapshot. So we've looked at all of the women who received thromboprophylaxis in pregnancy or for 6 weeks postpartum for more than 7 days. We've got 156 women and 230 pregnancies. At the moment, what we're doing is just risk stratifying them. We've got some women who are very high risk who will not be included in the final analysis, but this is how we've stratified our VTE risk. A low risk, a single provoked event, etc., etc. But just to give you a quick summary of the results, we have about 203 women who've received 40 milligrams of enoxaparin thromboprophylaxis. And in those women, we have only 1 woman who's had a breakthrough clot. And that was a woman who actually was on thromboprophylaxis. She had a very swollen left leg, which we scanned her for a clot. There wasn't a clot seen. Her leg would only be swollen when she was up and walking. When she lay down, it would be gone and the swelling would go down. So we put her on a prophylactic dose. About 2 or 3 weeks later, she was actually diagnosed with a high pelvic clot. So I think that was actually me missing the diagnosis and she should have been treated rather than a failure of thromboprophylaxis. We also had a couple of bleeds. Now, this one bleed, the first bleed, this is a woman who had lupus nephritis and severe hypertension and preeclampsia. She had a major intracerebral bleed, but it was 16 hours post-enoxaparin, and she had other risk factors. This woman died, though. And the second case possibly could have been attributable to thromboprophylaxis. She had a bleed into a pre-existing brain lesion and did recover. So I think what these bleedings suggest is that these drugs are not without risk. That's why I'm feeling very uncomfortable. I couldn't join the high-low study because I couldn't possibly get my patients funded to take anything other than thromboprophylactic 40 milligrams doses of enoxaparin in the system that I work in. And there's no way that I could afford or would feel comfortable saying to women that there's an imperative for them to join the study on the basis of what my clinical practice shows. So the last thing that really racks me up, as they say in New Zealand, is the dosing of thromboprophylaxis for overweight mothers. So in the UK, in the RCOG guidelines, you have very clear recommendations for dosing of low molecular weight heparin by maternal weight. And this is taken off across the world, let me tell you. A lot of people will do this. Now, this data comes from, this is what was quoted in the RCOG guidelines. It says that these are only suggestions and doses for obese women are not evidence-based. It says that in the UCOS study of PE in pregnancy, some overweight and obese women suffered a PE while receiving doses of low molecular weight heparin prophylaxis appropriate for women with weights of 50 to 90 kilograms. So it's suggesting, these overweight women got a PE in the UCOS study because they didn't get a dose that was high enough. But actually, you go back to that study, and of the women who had a pulmonary embolism who got thromboprophylaxis, they were all of normal booking weight. So they weren't over 90 kilograms, but 3 of the women received lower than recommended dose. 2 got dalteparin of 2,500 units, and 1 got 20 milligrams. So these weren't overweight women who were under-prophylaxed. These were normal weight women who were under-prophylaxed, because we would usually say it's 40 or 5,000 units that they get. So it may well be that the approach across the world is to not sit or lean on the fence, but to make dogmatic decisions. But my concern as a clinician is that if we over-recommend thromboprophylaxis, we will get people offside so that they decide not to thromboprophylax at all, even in women who are high risk. And I really, really do think that we need to look to opportunities ahead to develop optimal approaches, not just to diagnosis, but to treatment and prevention of VTE in pregnancy. Thank you very much.